Welcome back to another episode of Recharging the Human Battery here on AM 950 Radio. Dr. Sinacropi is out again today, so you've got me, the co-host, Mandi Dickey, nurse practitioner extraordinaire, as he always says. And I did not bring back the ABCs of concussion today. We did that last week with my little TBI takeover there, and I thought it might be a little too soon to do another one of those episodes. So we're going to kind of take it a little different look at things today, and I'm also doing things a little different. I have no notes, and I usually do. So we're going to see how this goes today. But I have learned a lot of things as I've gotten back into practice after my brain injury, and wanted to bring some of those things to you guys today. Hopefully we've got some listeners that are practitioners, because I have some advice for the practitioners in the world. And then we have kind of talked about this a little bit before in the past about advice for how to talk to your provider and what to do as you're going in and looking for healthcare advice. So I'll bring a little bit of that back today as well, and what you can do as the consumer in healthcare, as well as what providers can maybe do a little bit better. Because I think, as we've talked before, I was a nurse practitioner for 12 years in neurology before my own car accident that gave me the brain injury that I had. And I thought I knew a lot about managing concussion. I knew everything that they taught me in school, at least. Everything they taught me in school, everything that my colleagues taught me in practice. Those were the things that I was doing on a regular basis, sending patients to PT, to OT, PT for the balance work, OT for the fine motor skills, the vision skills. And then speech therapy was one thing that I didn't really do much from the concussion standpoint, but I did from the stroke standpoint. And that's another kind of thing that I want to talk about today too, is how similar really stroke and traumatic brain injury are. So my big primary focus prior to my accident was stroke management. And I ate, slept, drank, talked about it all the time. That was what I did on a regular basis in my practice, was stroke management. And for a time I did it in the hospital and the clinic, and then I was just hospital at the end. And again, that is what I did all the time. So I knew all the ins and outs of stroke management, everything that there was to be said in all of the stroke guidelines, the directives that are given to us from national databases and research that's done on stroke care. And that's what I was really good at. What I didn't really think about was that stroke and TBI are both brain injuries. They're both forms of acquired brain injury. So when you see information about brain injury, sometimes a lot of the time it will include stroke information as well. There are some differences, though. In these last 4 weeks, I've been spending time reading a new textbook from the Brain Injury Association of America as I'm getting ready to take a certification exam to be a certified brain injury specialist. You know, I'm certified in real life management after my own experience, but now I'm getting certified as a professional. And as I was reading through this entire textbook, literally front to back, and I think that's the first time in my adult life learning that I have read through a textbook front to back. But as I was reading through there, they often compared things from stroke and traumatic brain injury to look at the management and see if there are different guidelines that we have for stroke management that maybe we can take across to the TBI world, because there are so many similarities. And there are some things that do come across, and we can use those stroke guidelines to say, yes, let's do some of these things with traumatic brain injury as well. And there are other things that are clearly not able to be extrapolated from stroke management to TBI. So after the break, I'll come back and talk a little bit about what some of those things might look like. And again, some of those lessons that I've learned coming back to practice, and things that will help you as either the provider or as the consumer in healthcare. So lots of fun things to talk about today when we come back from this break here again on AM 950 Radio with Recharging the Human Battery. here on AM 950 Radio, Recharging the Human Battery. Again, Mandi Dickey, nurse practitioner, on solo today, talking about a little bit of everything with things that I've learned coming back to practice, things that I've learned in my latest research and readings that I've done related to concussion, brain injury. And again, no, this is not just a brain injury show, but when you get me on here by myself, those are things that I can talk about all day long and never get tired of talking about it. So as I was saying before the break, I was reading this textbook from the Brain Injury Association of America and going through all of the different guidelines, the information that we have for how best to treat patients with traumatic brain injury. And there are some things that I will say that are missing from that textbook, given the fact that I've learned so much in these last couple of years. But it really is pretty comprehensive for a mainstream type of book. So for all the things that were missing in there, it did really cover a lot of things pretty well that we really haven't talked about much before in my practice. So again, as I was going through nursing school, nurse practitioner school, my on-the-job training in neurology when I first started, I learned a little bit about concussion, and I thought I knew a lot of things. And I did the traditional referrals, as I mentioned before the break, the PTOT. Maybe not so much the speech, but getting them off to those different therapies, encouraging the rest initially. And as I've talked about here, I think with the ABCs of stroke, at least, if not with other shows too, is that we no longer are talking about taking all these rest breaks. And that's one of the things that I have learned in clinic. So as I'm talking to patients, as they're coming to see me at my position now in the clinic, we're going through what they've done, what they've been told by other providers, what we need to do for them still to help them get better. And one of the things that people are being told is to take that rest break, which used to be kind of the mainstay of treatment. Back in the day when we thought that everybody got better within a month, really, we were telling them to just take it easy and just stay in that dark room, brain rest, physical rest until your symptoms go away. Well, that could be a really long time for some people. And I've talked to people who are 9, 10, 17 years after their brain injuries. And if they would have been taking rest this whole time, there would be no movement whatsoever in their life. But taking rest, really, we know now that you shouldn't do that for much more than 48 to 72 hours. So yes, we want you to rest that brain and do not a lot of physical activity for those first 48 to 72 hours. Until the bulk of your symptoms kind of calm down a little bit. But then you really need to get back into some sort of activity. Start with activities of daily living, and that's just getting up, get a shower, get dressed, brush your teeth, eat, do meals, do the things that you normally do, and add in some light walking. We don't want anything strenuous. You don't want to jump right back into some HIIT workout, that high intensity workouts. We don't need that right away. We need just walking, something light. And then if it was a sports-related concussion, there are specific guidelines from the sports realm as we try to get back into sports activities and back to play. So there's a lot of talk about return to play and what those guidelines are. And if you are a young person that's still in school or even adult that's still in school, there are return to classroom, return to work things that we need to talk about as well. And getting back cognitively into those activities is really important rather than waiting on those activities. So the more you can try to get back in those early, the better off you will do. So we know that now, that we don't want you sitting out of those activities for a long time, because it's been proven that the longer you take to get back into them, the longer it's going to take to get back into your normal flow of life. So we really need to try to get people back into those activities sooner than later. And that's one of the things that I talk to people about in clinic all the time, is just getting back to their activities, even if it's modified, trying to do some of those things, but taking those scheduled rest breaks, because you're not going to be able to go back to your activities and do all the things all the time. I literally sat down with a patient this week and we talked about all the things that she's been doing, because she did a great job modeling and tracking it since the last time she saw me in clinic. And she was tracking her activities to see what she was doing and where she was getting triggered. And she was having a hard time finding where those triggers were. And she said when she gets tired from one thing, she goes and does something else, which, one, that's great, but two, you're still not giving yourself brain rest. So to the people that are still trying to recover from a brain injury, you need to take active breaks between activities. That does not mean you go from one thing right straight to the next, because you're still testing yourself cognitively, which over time, yes, that's going to be a good thing, but we don't want you pushing it to the limit every single day. So taking scheduled active rest breaks where you remove yourself from the stimulation that you're in. So once you start getting overstimulated, it's really easy to continue to get overstimulated. So if you're in a busy environment, you need to take a break away from that environment. Go to some place that is quiet for a few minutes, do some nice deep breathing and calm yourself back down again before you can try to get back into that. That's another thing that we've been talking about quite frequently on a regular basis in clinic as we're trying to talk to people about finding their balance now. Another thing that I've been talking to people about and wasn't really covered in that textbook that I read very well was the idea of acceptance. And I think I talked about it at least once on here again too, in the ABCs of concussion. But this is a part that really kind of gets missed by a lot of people. And as everybody is going through their recovery process, and not everybody's recovery process looks the same, but there are similarities. If there was any kind of trauma involved with the head injury, PTSD is very common. And PTSD and TBI together is a really bad combination. It slows down your healing. So people that have been in car accidents, people that had intimate partner violence, people that even in sports had a concussion from their sports activity might have some PTSD that helps them. It prevents them from getting back into their normal routine regularly because they have these PTSD symptoms that are keeping them down. And it was actually my PTSD therapist going through the whole car accident piece for me that helped me with this piece of acceptance. And again, if you heard me say this before, great. If not, it'll be new to you, but it's also a really good one. When you have pain, whether it's physical or mental, and you have non-acceptance, so pain plus non-acceptance meaning you are not accepting your current circumstances, that will lead to suffering. That same pain, again, mental or physical, plus acceptance, meaning you accept where you are. You don't have to like it, you just accept it, equals pain. That suffering part is optional. And I geeked out on this one because it reminded me of The Path to the Dark Side, if you're Star Wars fans. So my new goal was to avoid the dark side. And I have had that conversation with so many patients now as we try to figure out how to get to the next steps, because you have to get to that acceptance part in healing, whether it's a concussion, whether it's whatever chronic health condition you're dealing with. You have to get to that acceptance part. Again, you don't have to like it. You just have to accept what your current circumstances are and find a way to deal with those current circumstances. That will allow you to continue healing. It opens up a door that you didn't know was there. It's like playing a video game and all of a sudden you find a secret level. You hit that acceptance button and you get to that secret level that helps you improve a little bit more. So finding that piece in chronic health recovery is really, really important. And TBI, traumatic brain injury, has now been identified by the CDC as a chronic health condition. So we used to think of concussion, TBI, as a one-time event. So you had this traumatic event, whether it was a car accident, a fall, an abusive situation, whatever it was an event. You had the head injury and you recovered from it. So it was not thought of as something that lasted long term. We now know that about a third of all people will continue to have symptoms ongoing beyond a year, beyond 2 years in the research. And then again, some people just continue on having those symptoms, and then they learn compensatory mechanisms. So they have to learn how to compensate for those symptoms so they can get back to normal life. But it's not necessarily getting back to the same life that you had previously. So a whole nother topic there, but something to think about in the world of chronic health management and chronic health recovery. So the recovery does not always mean that you get back to 100% of what you were before. It means that you either get back some of those skills you had before, or you find new ways to do those skills. And that was a topic very well covered in the textbook that I went through as well, is finding these new levels, whether it is that repair, getting back to the old systems, or whether it's recovery and accommodation, learning how to compensate for the skills that you don't have anymore and doing things in a different way. We've talked about that a lot. If any of you listen to my podcast, I've had a couple of guests on there recently where we've talked about mental health skills and how to find new ways of doing things. I had a psychologist from New Zealand on my show last week, and we talked about how you can learn new ways to do things and use neuroplasticity to your advantage. Again, neuroplasticity is that ability to form new connections in your brain. And that is not something that's just in kids. We think about it all the time and say, oh, kids that have head injuries when they're younger, they have concussions when they're younger, they bounce back so quickly. But as was highlighted again in this textbook that I was just reading, that it's not just the fact that they recover. It's they look okay in the moment, but we can see long-term consequences still showing up for these kids later on because there were still changes in their brain, but it's just not manifested the same right away. So yes, while we often think that kids bounce back really quickly, later on in life, they're getting diagnosed with things like ADHD or attention issues. And we think that it just comes out of the blue and that it's a single diagnosis by itself, when in reality, a lot of those things are probably related to the head injury that was received earlier in life. And we just don't put those two things together. So the next lesson that I want to talk about is the idea that not all of our concussions are diagnosed. And I think a lot of people know that already, but as you kind of think back in your life, there are experiences that we all have that we say we got our bell rung or we saw stars or we had some sort of episode, and we don't really attribute that to a head injury. And I want to remind you again that concussion is a mild traumatic brain injury. That is the definition of a mild traumatic brain injury. And when we think about this, mild does not relate to the severity of the symptoms. So I'll talk about that real quick too. And this is another conversation that we've had quite frequently in my clinic office with patients, is that mild does not attribute to the symptoms. It only attributes to the symptoms that you had when you first had the head injury. So our current ratings with concussion are mild, moderate, and severe. They're not great. It's a tool to help us identify the severity of the concussion immediately when it happens. So a mild traumatic brain injury, currently, again, mild traumatic brain injury equals concussion, same thing. A mild TBI is considered something that does not have loss of consciousness, may or may not have any other physical effects. So you don't have a loss of consciousness with a mild TBI. If you had any loss of consciousness whatsoever, that automatically puts you up into the medium category, the moderate category, if not severe. So a moderate TBI would include loss of consciousness anywhere from 0 minutes to 24 hours. So anything from 0 to 24 hours. Up to that 24-hour period, with or without changes, is considered a moderate TBI. If you had a loss of consciousness greater than 24 hours, you had a skull fracture, you had internal brain changes, brain bleed, that would put you into the category of a severe TBI. And that is the only thing that matches that severe TBI diagnosis right now. So again, that diagnosis is only the event itself. So greater than 24 hours loss of consciousness, up to 24 hours loss of consciousness, no loss of consciousness is kind of your diagnosis criteria for the mild, moderate, or severe TBI. It has no relationship to symptoms, because we now know, again, that about a third of those people that have mild TBI continue to have debilitating symptoms beyond a couple of months, where we used to think that they all got better within a month. Not so. So that's a lot of conversations that we have are those symptoms, and kind of thinking about where we're going with those. So again, thinking about whether or not you get this diagnosis of TBI. I have had the conversation with a lot of people, because if you've had previous concussions, it's going to make your current concussion take a little bit longer probably to heal. And that's not the 100% rule. It's not the golden rule with that. So there are some people who have never had any kind of concussion before, and this is their first concussion, and it's taking a lot longer to recover than they thought. And then there are people that have had multiple concussions and they get better just fine. I can't tell you what all of those factors are. There are so many factors that go into that. But sometimes I can look at a person's history, and I think that this is going to be a concussion that's going to last them a little bit longer. But by the time they come to see me at the next appointment, they're almost back to normal again. They're back to work. They're doing great. They just have a few little things that they're dealing with. So it's very, very variable when I see patients, what it looks like. So again, thinking back to whether or not they had any previous concussions, that sometimes requires a little bit more thought. And sometimes it's obvious. We can say, yep, I was in a concussion, or I was in a car accident and hit my head. And I don't really remember how long symptoms lasted, but yeah, I hit my head. Or, yep, I was a football player and I saw stars a couple of times. Probably had a concussion, but I never got evaluated. And then there are people who have stories of when they were younger, like 2, 3 years old, they fell out of a 2 or 3 story window and nobody really evaluated them because they didn't have symptoms at the time. So they don't think about it as being a previous head injury until we really talk about it in this context of you don't have to hit your head. You don't have to lose consciousness because only about 10% of people lose consciousness. And probably about half of people actually hit their head. The rest of them are from the inertia of the brain moving, or if it's military, it can be from blast injuries, which that's actually equivalent to multiple concussions at the same time. So people don't always put 2 and 2 together to think of this previous episode as a brain injury. And when we talk about that, then I tell people again, less than 10% lose consciousness, only about half hit their head. I'm like, given that, did you have any experiences previous in your life that may have resulted in a concussion, whether or not you got it diagnosed? And so many times things are coming up. And then there's this whole other avenue of intimate partner violence where people don't like to admit their symptoms, especially if their partner is with them when they come to the emergency room. They're going to make up a different story of why this might happen because they're afraid. And in healthcare, we need to be able to tease that out a little bit and identify when something sounds a little fishy and when we really need to make sure that the patient is alone in the room so we can get more information. Because I've had some patients come into my clinic and they say, when I went to the emergency room with this injury a couple of years ago, I didn't tell the whole truth because I was scared, but that person's no longer in my life. So now I feel like I can tell this. And then we address the fact that, yes, a brain injury occurred during that episode, and that does play a role in how well you're recovering from this new brain injury. So that's another avenue that we really need to start being a little bit better about. And one thing that was highlighted again in this BIA textbook was that the COVID, the whole pandemic where people were forced to be inside and forced not to leave their homes, that increased domestic violence, the intimate partner violence, because people couldn't get out of the homes. They couldn't access healthcare as well. And it led to so many more cases of intimate partner violence. And we didn't have the resources going out into the homes to help these people. So case managers, program managers, in-home healthcare, none of those were going into the homes to help check on people, do welfare checks, make sure that they had the resources that they needed. And we really had an increase in those violence cases during that time frame. So when things like that happen in our society, we need to think about the secondary effects and what happens to those patients and how can we potentially make life a little safer for those kind of individuals in those situations. So lots of lessons that I've learned, lots of things that I've learned from reading this textbook as I prepare for my certification. The last chapter in that textbook was on the military. And I was a little disappointed because this chapter in itself was 3 pages, just going through a little bit of what happens, what's different for our military members. And we have so many veterans that we have kind of let fall through the cracks. And I've seen a couple of them in clinic now, and it's not identify that they have brain injuries all the time. If they didn't clearly have symptoms, it's not really dealt with. Again, the PTSD part of it comes in huge when they have that combination of PTSD and TBI together trying to recover. So I was really a little disappointed that chapter wasn't a little bit longer with more resources for what to do. I did find out, though, that we have done some things to improve the technology for our military members, and I hope that this is an across-the-board thing where the helmets are a little bit better, prevent them from direct damage, prevents them from explosions, potentially causing things to penetrate into the skull of the individual that's in the military. They have done some upgrades on the military vehicles to try to prevent things from going through the vehicles and causing penetrating injuries. and just trying to mitigate the blast injury, because that's where we see most of this. And it's not, again, it's not a visible thing. So when we talk about concussion, it's always the idea that it is an invisible disability, but it might be even more so with these blast injuries, because you don't see it unless there was an IED or some other kind of explosion where there's shrapnel that you can actually see physical damages on the person. Most of this is going to be invisible and you don't see it, but you get those multiple reverberations of vibration in the skull that causes what appears to be multiple concussions at the same time. And if you think about it, we've talked before on this show about if somebody has a concussion and they have a second impact within the time frame that they're trying to heal, we call it second impact syndrome, and that can lead to permanent brain damage. So if you think about this person who's now had multiple concussions from a blast injury at the same time, that increases their risk for permanent brain damage if we're not doing something different with it. And another really kind of related but really cool experience I had this week was going down to the Vikings training camp and meeting with athletic trainers in their department, and going through seeing what our Minnesota Vikings, what our players go through and what the team goes through as they're getting ready for play, as they are getting evaluated if they potentially had a concussion on the field. It's pretty robust program that they have, and I was quite impressed with it. But as we were talking about, again, those second impacts, it really relies a lot on people around them being aware. So in any level of sports, it requires people being aware of the person, any kind of little differences that they might have in their personality. If they had some sort of impact that could have caused a head injury, being alert and monitoring those symptoms and taking them out of play when this happens and not letting them return until they've been cleared. So this clearance process is really important to make sure that the players are not then returned back to that sport so that they can have a second injury. Because again, that second injury leads to what we call second impact syndrome, can lead to permanent brain damage. It can lead to degeneration. Over time, it leads to this thing that's started to make its way into the media is chronic traumatic encephalopathy, CTE. We've seen that in several former NFL players. We've seen that in boxers. Muhammad Ali was one famous one that we've seen this happen in. And they start looking like they've got degenerative changes like Parkinson's or Alzheimer's. And it's a similar process that's going on, but also at the same time, it's been identified to be a very much different process. We can only clearly diagnose CTE on autopsy, but we can see signs, similarities, things that might suggest that they have CTE. And this is one thing I actually talked with the associate head of the athletic training department with the Vikings on Monday, was that there was a research study done last year. And I remember around the time of the Super Bowl, I was posting information about it. So I don't have the exact reference on me at the moment, but there was a research study done last year that was just posted about looking at former NFL players and whether or not they had evidence of this chronic traumatic encephalopathy. And a whopping 90% of the players that were involved in this research study showed evidence of CTE. They showed evidence of this chronic traumatic encephalopathy. So from years of having concussions, they're showing these degenerative changes in their brain. Again, we can only clearly identify it on autopsy by looking for a specific protein on the brain that shows up after these traumatic injuries. But we can see that evidence and what it looks like, and how the NFL see that players are getting evaluated and cleared before they return to play so that we don't have that increased risk of second impact syndrome, which ultimately will potentially lead to that development of chronic traumatic encephalopathy. So there's a lot of things in play. And unfortunately, again, I don't like getting really political, but this year, as they were making all the changes in Congress and making all the changes with the standards that we have in place, we had a really good program with the CDC that did the research on TBI, watched the statistics, watched the numbers, tried to figure out what we can do to prevent concussions or do better management in the future. And that research department has been kind of wiped clear. So we need to wait for some other changes to happen at that governmental level so that these programs and research departments can get reinstated and get things going again. Because until that time, we can't make any headway, for lack of better terms on that one, pun intended, I guess, on improvements in the concussion realm. So a lot of things are kind of in the lurch right now. What can we do for these concussion patients? So if you are that provider listening, one other thing that I've heard a lot this week is that patients have told me they felt heard. They felt validated because I've listened to their concerns and I've explained why they still have these symptoms. Because of this extra education that I've received from my own head injury, it's forced me to learn more about what happens with a head injury. So again, I mentioned earlier, I thought I knew so much about concussion management until I went through my own experience. Learning from it personally, having those symptoms personally, really made me interested to find out, why are these things happening? Why does it happen to some people and why does it not happen to others? And what exactly is causing these changes in the brain? So through all of that research, it made me a more open-minded provider. And it made me more educated. So rather than saying, I don't know, or, oh, you'll be fine, just give it time, which is what these patients are being told from other providers they're being seen, is just give it time. We'll wait a little bit. We won't refer you to neurology until X months have gone by, because up until that point, you're likely to just get better. So people are waiting 4, 6, 12 months before they get referred to neurology, because in primary care, many of them are still under the belief that it's just a matter of time and you'll get better on your own. Well, when Dr. Sinacropi first got me into hypercharged wellness, when I had my injury, 6 months had gone by and I had done everything inside the box. And Dr. Sinacropi said, we want you to get better. We want you to get on this team, because my neurologist even had said at that point that we've tried everything inside the box. We need to look outside the box now. And it's those outside the box thoughts that help people get better. That's what helped me get better. I still did my PTOT. I started speech after I started treatments at Hypercharged Wellness. But getting into those other therapies, that's what made the big difference for my recovery. And that's what helped me, I believe, get back to doing the job that I'm doing now, because I did things like the red light treatments, the transcranial laser, the PEMF the NanoV structured water, even the EWAT. And I wasn't really a huge fan of doing exercise with oxygen therapy at first, but I learned to absolutely love it. And I love the days that I had time to do that in my therapy. Those kind of treatments, as well as the things I did outside of Hypercharge, the neurofeedback, the vagus nerve stimulation, all of the other treatments that I did, and then the neurological chiropractor that I started working with beginning of this year, looking at things from the outside the box lenses. And even since then, I have connected with a lot of people as I've been starting my program and making sure that I have connections all over that I can send patients to make sure that they're getting all of the treatment that they need. I have connected with audiologists, with neurooptometrists, looking at all the different ways that we can try to help people get better. I got my own hearing testing done and found out that I do have a form of auditory processing disorder, which is much more common after concussion than I thought. And going through all of these experiences has given me that bigger network that I can send patients to. And it's not to sit here and toot my own horn, because that's not the kind of person that I am, but it's to give an example of what other providers can do to make sure that they're doing everything possible for their patients. Because that's why we got into healthcare, is that we wanted to help people. So we have a little bit of training in school on a little bit of everything. And my nurse practitioner license degree is in family nurse practitioner. So I literally was taught everything from birth to death. Does that mean I'm an expert in everything from birth to death? Absolutely not. I know that hormones are a major part of recovery after a concussion, but I'm not going to try to manage those hormones myself. I'm going to refer them to a women's health or a men's health provider to get those hormones evaluated. I know that cognition is a problem, but I don't try to deal with it myself. I refer them to speech therapy for therapy, for the cognitive therapy. I refer them to neuropsychology to get testing done. I refer them to mental health providers to work on the mental health part of it, because I'm not an expert in every field. I am the expert of the things that I have had experience with and that I've seen a lot and that I've done a lot of research on. And concussion is my thing, but again, I'm not going to manage individually every single part of that because it takes a village to help somebody recover from concussion. But it's knowing our connections. It's knowing that when they have these symptoms that sound like auditory processing, I'm going to send them to an audiologist to get tested. When they have problems with their vision, they're seeing double, or not even just double, they just can't see clearly. They wake up and it's really hard for them to focus and see things clearly, or everything's kind of blurry, or they're very sensitive to light, or when they look from side to side, they get this trail of light or color behind them because their eyes are not tracking together. I know I need to send that person to neurooptometry to get that further evaluated and see what exactly is going on. So it's knowing who to get involved and when, and what patients need. It's knowing that if they had a history of COVID infection and multiple concussions, that's the kind of person I definitely want to make sure that I send down to Hypercharge Wellness so that they get that red light therapy and they can try to get better from that, because I've done it myself. I've sent other patients there and I know it works. There's research that's been out there for decades on these treatments, but it just hasn't made it to mainstream, as we've talked about multiple times on this show. It's just not in the mainstream literature, and it's not on the mainstream medical education. So if you only stick to what you've learned in school, yes, you'll know a lot, but you're not going to know everything that could potentially help your patient. And one thing that I like to do is learn about all the new things that are coming up. If I hear something about it, I'm going to do some research on it, because I'm probably going to have a patient at some point ask me. We all have access to the internet, for good or bad, and we can find a lot of information on there. And as providers, we really should be knowledgeable about these things so that when patients come into our office and they ask a question about it, we can give an honest answer and say, I just read something about that, and it might be helpful for you or it might not be helpful for you. And use Google as your friend at that point then to look up some articles. You can do a quick little Google Scholar search and find some research articles on all of these things. And it might not be the New England Journal of Medicine, but it might be this other little side journal that you didn't even know existed, but there's research on it. So as providers, again, my request to you is to be open-minded. Look for things, realize that there's something out there that other than what you learned about in school, because the textbooks we used in school 20 years ago only had the knowledge from that point. It didn't tell you the future of what was coming. And there's still so much ever changing all the time. So rather than listening to your same requirements from the Cardiology Society every year on what kind of blood pressure managements you might have, maybe branch out and look for other kind of continuing education about new and up and coming things in concussion and head injury, for example, because that will give you a taste of what's out there, what's coming. I'm going to be trying to do some education for the primary care providers around me, at least up in the Coon Rapids area where I'm working in clinic now. And I'm trying to do a lot of education through my podcast. So again, if you're not listening to that, Brain Wellness, the podcast, I talk so much about concussion now. It didn't used to be all concussion before my accident, but it's more concussion than not now because there's just so much to cover on that. So you're welcome to listen to those things. Look for new conferences, new presentations, new webinars, something to help you realize what all is out there now and what options you have. And as the individual, the consumer in healthcare, the patient, the family member, the caregiver, again, I give lots of tips every week when I do the ABCs of concussion because there is so much to cover. But as that consumer, you need to be knowledgeable yourself and don't feel bad about looking up research and looking up some kind of treatment and bringing it in and asking your provider if that particular thing might help you, because I'm always willing to look at it. I wish all of my peers were, but again, this is a request to have people be a little bit more open-minded on that. But do some research, look for some things that might help you get better, bring that to your provider. And if you're not getting the answer you want, I need you to look somewhere else and keep looking for somebody that will be open-minded on that, because you'll find it. So more to come after we take this last break here today. We're having a great discussion. I'm kind of impressed with myself today. So AM 950 radio, recharging the human battery. We'll see you back after the break. All right, welcome back one last time here on Recharging the Human Battery on AM 950 Radio. Again, Dr. Cinecrope's out today. You've got me, Mandi Dickey. I've been talking today about all sorts of things related to concussion, TBI, stroke, provider recommendations, patient recommendations. Again, we kind of had to laugh a little bit as we were taking the break because I have no notes today, and I'm not usually a no notes kind of person, but I'm learning my passion technique from Dr. Cinecrope on the show here, going with no notes. So we've been having a really good conversation today. And again, if you are just tuning in now, make sure you go back and listen to this episode because it's been a lot of fun to talk about all the things related to concussion that I've learned about in clinic, lessons that I've learned from clinic, lessons that I learned from reading an entire 25 chapter textbook from the Brain Injury Association of America, getting ready for my certification exam. Just a lot of information to learn. And again, I kind of joke, I got the personal experience, that personal certification from 2 years of recovery from my own accident where I sustained a so-called mild traumatic brain injury that was not so mild after all. And as we talked about before in the main section of this show today, is that mild TBI diagnosis is kind of a misnomer because it gets you the severity of the initial injury, but it doesn't get you the severity of the debilitation overall. And it leads to a lot of disability. Brain injury is one of the leading causes of disability and unemployment in the United States, and it's a leading cause of disability across the world, actually. So this is not just a United States problem. This is not just a sports problem. It's not a problem of any particular race or ethnicity or gender. It's a problem that crosses all of those borders. And because it crosses all of those borders, we really all need to have a little bit more education about it. We need to all understand the importance of it so that we know if we sustain a brain injury in our lifetimes, what is that going to mean for us as we get older, as we age, because there are different age effects as well. As we all age, we have some atrophy of our brain. Atrophy means shrinking. So our brain shrinks in our skull as we age. It's just a natural process. How that shrink is going to be a little bit different, whether you've had a stroke or a brain injury or something else happen inside of your skull that then changes the anatomy and it changes the structure of your brain over time. And if you've had one or more concussions, that will have an impact on how you age and how your memory performs as you age. There are things that we can do to help our brains heal. There are things that we can do to help our brains age. There are a lot of vitamins that I like. So vitamin B, the B vitamins are really good for brain, for your nervous system. Magnesium is really good for brain healing. Vitamin D, living in Minnesota, we are essentially all deficient in vitamin D because the sun is our only natural source. Vitamin D is a really good brain healing supplement. So getting these types of brain heal, it helps our brain age better. CoQ10, curcumin, prescription medications. And again, we never like to say that prescription or medications are the devil. There is a purpose for them, just like there's a purpose for supplements as we go through. But even more than that, sleep is the number one thing that I talk about with people in my concussion clinic, because if you are doing everything else right and you're not sleeping, you're not going to get better. And I actually had that conversation with a patient this week too. And his wife took down the notes and said that sleep would help him get better if he did nothing else. And it is absolutely true. So there are things that you can do to help yourself heal. And just because you've had a head injury, just because you've had multiple head injuries, does not mean that you cannot age gracefully and learn to manage the symptoms that you have and learn to live a good, fulfilling life. I'm doing it. You can too. So if you have questions, you can always leave a comment on the show, and either someone from the radio station or myself will get back to you. There's a lot to talk about with concussion, so I'll be back in other weeks to do the same thing. So thanks for joining me today, guys. Go out there, be healthy, take care of your brains, because you only have one and you can't get a transplant at this point. Recharging the Human Battery here on AM 50 Radio. Thanks for being here today, guys.